silence, handling these, complex chemical processes without a single hitch. Now imagine the clean room is inside you.
Okay.
It's your peritoneal cavity. Under normal circumstances, it's this slick, well-oiled machine that lets your organs just slide past each other, digests your food, and, well, keeps the engine running. It's a biological sanctuary.
It really is an engineering marvel. I mean,
Yeah.
you've got the sealed sac, the peritoneum, and it demands absolute sterility to function. Has to be perfect.
But here is the nightmare scenario. Imagine a seal breaks in that clean room. And it's not just a slow leak, it's a catastrophic breach. Suddenly you have a Pandora's box situation. That pristine environment turns into a biological battlefield in minutes. We aren't talking about a stomach bug or a bad flu. We are talking about a flash flood of infection that can shut down every major organ system you have in a matter of hours.
That imagery is intense, but honestly, it's not an exaggeration. When we talk about intra-abdominal infections, we're talking about the body's internal containment system failing.
Right.
And when the peritoneum, that lining of the abdomen, gets compromised, the body doesn't just whisper a complaint, it screams.
Which is exactly why we're doing a deep dive into this today. On the surface, intra-abdominal infections sounds like the dry title of a medical textbook. I think it's chapter 42, if anyone is checking.
It is, yeah.
But when you actually get into the mechanics of this, it is a story about biological warfare, incredible bacterial alliances, and the high-stakes decisions doctors make when the body is literally collapsing on itself.
It's one of those topics that sits right at the intersection of anatomy, microbiology, and, emergency surgery. It forces us to ask, what happens when our internal borders fall? And maybe more importantly, how do we fix a machine that is actively trying to destroy itself to stop an invader?
So our mission today is to decode that chaos. We're going to look at the two main ways this war plays out. The flash flood of peritonitis versus the fortress of an abscess.
A great distinction.
We'll look at the bacterial armies involved, because it turns out they work in teams. And we'll unpack the concept of source control, which, by the way, sounds like it's probably the most important concept in surgical medicine.
Oh, absolutely. Source control is the golden rule here. But before we get to the solution, the counterattack, we have to understand the terrain. You keep mentioning the peritoneum.
Right. The battlefield itself.
So think of the peritoneum as the shrink wrap of the abdomen. It's a very thin, serous membrane that wraps around almost everything. The stomach, the liver, the intestines.
All of it.
Almost all of it. And it creates what we call a potential space. Normally, there is just a tiny bit of fluid in there, maybe 50 milliliters, to lubricate things.
So your intestines don't stick together when you move.
Precisely. It lets everything slide around smoothly. But crucially, in that fluid, there are zero bacteria. None. It has to be sterile.
It's that clean room.
Exactly. An intra-abdominal infection is basically defined as a breach of that clean room. Any infection contained within the peritoneum or the retroperitoneal space, which is just behind it, falls into this category.
Okay.
And generally, the body responds in one of two ways. It either tries to fight it everywhere at once, that's peritonitis,
Yeah.
or it tries to wall it off and contain it, and
Yep.
that's an abscess.
Let's start with the everywhere at once scenario. Peritonitis. I hear I immediately think inflammation. Arthritis, tonsillitis. So this is just an inflamed belly lining.
Just is doing a lot of heavy lifting there. Yes, it is inflammation, but you have to think about the surface area. The peritoneum is huge.
Yeah.
If you can somehow unfold it and lay it flat, it's about the size of your skin.
The entire surface area of my skin.
Pretty much. So imagine having a burn or an infection that covers your entire body, but it's on the inside. That is peritonitis.
Yeah.
It's an acute, massive inflammatory response because the body has detected something that absolutely should not be there.
And is it always bacteria? Or can other things trigger this?
Not always, which is a really fascinating distinction. The lining is incredibly sensitive. It can react to chemicals like if a stomach ulcer bursts and pure stomach acid spills out. That's chemical peritonitis.
Wow.
It can react to irradiation. It can even react to a foreign body, like a surgical sponge left behind, God forbid.
Yikes.
But usually, and for the sake of what keeps surgeons up at night, we are talking about bacteria.
Yeah.
And this is where we have to draw a really important line in the sand between primary and secondary peritonitis.
Okay, I've seen this distinction. Secondary sounds like the one most people would recognize, the more dramatic one.
Yes. Secondary peritonitis is the explosion. It's secondary because it happens after something else catastrophically fails. There is a clear structural problem in the abdomen.
Like a burst appendix. That's the classic example.
Exactly. Appendicitis, a perforated ulcer, a traumatic injury from a car seatbelt crushing the intestine, or diverticulitis, where the bowel wall just erodes and pops. In all these cases, you have a physical hole, a leak.
So you're taking the contents of the gut, which is what, teeming with billions of bacteria?
Trillions, actually, and you're pouring it directly into that sterile peritoneal space.
So that's the breach. You got a hole in the hull. Simple as that.
Right. But then you have primary peritonitis. This is much more insidious. It's spooky. In primary cases, there is no hole. You can scan the patient, you can open them up in surgery, look at every inch of the gut, and you won't find a leak.
So how do the bacteria get in? They can't just teleport.
It feels a bit like they do. The bacteria usually travel through the bloodstream or the lymphatic system from an infection somewhere else. But there is another mechanism called bacterial transmigration that is honestly a bit terrifying.
Transmigration? It sounds like a ghost story.
It acts like one. Under certain conditions, bacteria can actually migrate through the intact bowel wall. They essentially phase through the barrier without leaving a hole.
How is that even possible?
It usually happens when the patient is already very sick, often with severe liver disease like cirrhosis. They get this fluid buildup in the belly called ascites.
Right.
That fluid is stagnant. It's a perfect petri dish.
Right.
And the bowel wall becomes swollen and permeable. The bacteria just seep through.
That is incredibly unsettling. It's like the walls of the house just stop working.
It is. And there are other sneaky routes. In female patients, the peritoneal cavity is technically open to the outside world via the fallopian tubes, so bacteria can ascend that way and cause an infection.
I never would have thought of that.
And in patients who are on peritoneal dialysis for kidney failure, they have a permanent catheter tube sticking into their belly. That is a direct highway for skin bacteria to march right in.
Okay, so that's peritonitis, the widespread invasion. But you mentioned the body has a second strategy, the abscess. You called it a fortress earlier.
Right. So if peritonitis is a wildfire spreading uncontrollably, an abscess is the firebreak. It represents the body realizing, I cannot win this war on the open field, so I'm going to contain the enemy.
So it's a defensive move?
It's a last-ditch defensive move. An abscess is a purulent collection, which is just a medical term for a pocket of pus that is physically separated from the rest of the abdomen.
So the body actually builds a wall around the bad guys?
Literally.
Wow.
The immune system recruits inflammatory cells and this stuff called fibrin, which is like a biological glue, and it even grabs nearby organs like a piece of intestine or the omentum.
The omentum, what's that?
The omentum is a fatty apron that hangs down from the stomach. We sometimes call it the policeman of the abdomen because it moves to areas of inflammation and tries to patch them up.
So it's like a mobile repair unit.
Exactly. And it will plaster itself over the infection along with other loops of bowel to form a capsule. It traps the infection, walls it off.
That sounds beneficial. I mean, better than a wildfire.
It saves your life in the short term, absolutely. It stops the widespread sepsis from killing you immediately. But inside that wall, it is a nightmare. It's filled with necrotic debris, dead tissue-life bacteria, and white blood cells. And here is the key detail that changes everything about how we treat it. Inside that abscess, the oxygen level drops to almost zero.
It's an airless bunker.
It's anoxic.
Yeah.
And that environment changes the game entirely because it selects for the nastiest types of bacteria. The ones that need oxygen, the aerobes, they die off. And the anaerobes, the bacteria that thrive without oxygen, they take over. They dig in for a long siege.
So we have the open war of peritonitis and the siege warfare of the abscess. I really want to dig into how this actually kills you, because it's not just I have an infection and I feel sick. The physiology here seems incredibly, incredibly violent.
It is violent. Let's trace the path of a secondary peritonitis case, say a perforated diverticulitis. You have a hole in the colon. Feces and bacteria pour out. They don't just stay in one spot. The natural movement of the abdomen, even just from breathing, disperses them. Suddenly, the entire peritoneal lining is inflamed.
And this is where we run into this concept of third spacing. I've heard doctors use this term and it always sounded abstract, but reading into this, it sounds like the actual mechanism of death.
It is the mechanism of shock, absolutely. To understand third spacing, you have to realize that inflammation makes your blood vessels leaky. The body is trying to send white blood cells and proteins to the fight, so it dilates the vessels and makes the walls permeable.
Like opening the floodgates to let the soldiers out.
Right. But in the abdomen, The surface area is so massive that when those floodgates open, the fluid doesn't just wet the tissue, it pours out of the circulation. You lose liters and liters of plasma-rich fluid out of your veins and into this useless third space in the abdominal cavity.
So wait, let me get this straight. You're filling up with fluid, your belly is getting distended, but you are dehydrating at the same time.
That is the deadly paradox.
Yeah.
You are drowning in your own fluids internally, but your blood vessels are running dry. A patient can be swollen and distended, looking like they are retaining water, but their heart is trying to pump a completely empty system.
That's terrifying.
It causes severe hypovolemia, which is just, like you said, low blood volume.
And that leads to the crash.
That leads to the crash. Hypotension hits, blood pressure plummets. The kidneys stop getting blood, so they shut down. The brain stops getting enough oxygen. You go into shock. And at the very same time, the bacteria are releasing endotoxins that are poisoning the heart muscle and the lungs. It is a complete systemic collapse. The infection lights the match, but the fluid shift is the explosion.
That puts a whole new perspective on stomach pain. Wow.
Yeah.
Okay, now I want to look at the invaders themselves. You mentioned earlier that this isn't usually a lone wolf situation. You called it a bacterial alliance.
Yes, and this is one of the most fascinating parts of the microbiology. In secondary peritonitis, it's almost always polymicrobial. It's a party. When we take a culture from an infected site, we usually find an average of 3 to 4 different types of organisms.
And they're not just random neighbors living together?
Not at all. They have a strategic symbiotic relationship. Or maybe synergistic is the better word. They work together to kill you.
How does that work?
So you have 2 main classes of bacteria in your gut. Aerobes, which use oxygen, and anaerobes, which hate oxygen. In a healthy gut, they live in balance. But when they get loose in the belly, they form an alliance.
Give me the war room strategy. How does an aerobe help an anaerobe?
Okay, so think of a common bug like E. coli. It's what we call a facultative aerobe. It can live with or without oxygen.
Wow.
It's tough. So it enters the peritoneal space first. It's aggressive. It causes that initial massive inflammation and the sepsis.
It's the first wave of the attack.
It is. But its main job in the alliance, it consumes all the oxygen in the immediate area. It just gobbles it up.
It sucks the air out of the room.
Exactly. And by doing that, it terraforms the environment. It creates a low oxygen anoxic zone, perfect for the heavy artillery, the strict anaerobes.
And who are they?
The main one, the king of the anaerobes, is a bug called Bacteroides fragilis. B. fragilis can't survive in fresh air. It's instantly killed by oxygen. But thanks to E. coli doing all the prep work, B. fragilis can now thrive, multiply, and it's the primary bug responsible for building that abscess wall we talked about.
That is diabolical. So E. coli is the shock trooper that breaches the gate and causes the initial chaos, and then B. fragilis is the engineer that comes in behind and builds the fortress once they're inside.
That is a perfect analogy. And this synergy dramatically increases lethality. If you were to inject just E. coli or just B. fragilis into a lab animal, it might get sick. But if you inject both together, the mortality rate skyrockets. They protect each other and enhance each other's virulence.
Is it always this complex team, or do you ever see solo acts?
The solo acts are usually in primary peritonitis. In children, it's often just a Streptococcus species. In those cirrhosis patients with ascites, it's very often just E. coli that has seeped through the bowel wall.
And the dialysis patients?
For the dialysis patients, it's usually skin flora bugs like Staphylococcus epidermidis or Staphylococcus aureus that crawl down the catheter tube. Those are single organism infections. But for the big surgical emergencies, the birth bowels, it's always the alliance.
There was one other bug the notes mentioned, Enterococcus. It seemed like the text was a bit ambivalent about it. What's its deal?
Enterococcus, the mystery guest at the party. We see it all the time in cultures from abdominal infections, especially in patients who have been in the hospital for a while or had surgery before.
So it's there, but is it doing anything?
That's the huge debate in the medical community. Is it actively hurting the patient or is it just hanging out? Is it a pathogen or a bystander? It's often a marker of a really sick patient, someone whose host defenses have failed, but we don't always know if targeting it specifically with antibiotics changes the outcome.
So it's the bystander that might be an accomplice.
That's a great way to put it. We tend to treat it in very high-risk patients, but for a standard case, its role is still unclear.
So we've got the terrain, the mechanism of shock, and the enemy alliance. Now let's go to the bedside. What does this actually look like for a patient? The notes describe a tale of 2 patients, and the difference is truly night and day.
It really is. Let's start with patient A. This is your classic secondary peritonitis, the perforated ulcer or the burst appendix. This presentation is unmistakable. You can diagnose it from the doorway.
I've heard the phrase board-like abdomen. That sounds incredibly visceral.
It's something you never forget once you feel it. It's not just that their stomach is hard. It's rigid. It's a reflex. The muscles of the abdominal wall go into a violent, involuntary spasm to create a shield over the inflamed organs.
But you can't even push on it.
You cannot push on it.
Yeah.
The patient will be lying perfectly still, maybe with their knees bent up, because every tiny movement, every vibration, even a cough, causes agonizing pain.
And I assume the rest of their body is signaling emergency.
Oh, loudly. Their heart rate is through the roof tachycardia. They're breathing fast and shallow tachypnea. They usually have a high fever, 100 to 102 degrees Fahrenheit.
And if they're in that third spacing phase?
Then their blood pressure is dropping. They look pale, clammy, toxic. Their labs will be a mess too. A really high white blood cell count, leukocytosis, with a lot of immature cells we call bands, which means the bone marrow is panicking and pushing out baby white cells to fight.
And the gut itself, is it still working at all?
No. It shuts down completely. It's paralyzed. We call it an ileus. If you listen with a stethoscope, you hear nothing, just deadly silence.
Okay, so patient A is screaming for help with every sign and symptom, but patient B seems much scarier to me because they are so quiet. This is the primary peritonitis, or the dialysis patient.
Yes, this is the subtle presentation, and it is a trap for unwary doctors. These patients might not have that board-like rigidity. They might just complain of being a little nauseous, maybe some mild diffuse tenderness.
Why the huge difference?
Well, in dialysis patients, for instance, their abdomen is already used to having 1 liter to a fluid in it for dialysis, so the lining isn't as reactive to the new infected fluid. And in those cirrhotic liver patients, their immune system is so shot, they can't mount that massive inflammatory response. They might not even have a fever.
So how on earth do you catch it? What's the clue?
For dialysis patients, the telltale sign is the fluid itself. When they drain the dialysis fluid from their abdomen, it should be crystal clear like water. If it comes out cloudy or milky, that is the alarm bell. It means it's full of white blood cells.
So you have to actually look at the fluid.
We have to. You have to be suspicious. You send that fluid to the lab, and if the white blood cell count is over 250, that's the diagnosis. You have to be almost paranoid to catch patient B. If you wait for them to look like patient A, it's often too late.
This brings us to the counterattack. How do we save these people? The strategy seems to rest on 3 distinct pillars.
It's a tripod. And if you miss one leg, the whole thing falls over. The pillars are surgical drainage, hemodynamic resuscitation, and antimicrobial therapy. And the order really, really matters.
Let's talk about the big one first. Pillar 1, source control. The sources make a huge deal out of this. It feels almost philosophical.
It is the single most important concept in treating abdominal infections. It distinguishes this from almost every other kind of infection you can think of.
How so?
Well, if you have pneumonia, you give antibiotics. If you have a urinary tract infection, you give antibiotics. But if you have peritonitis from a hole in your colon, antibiotics alone will fail 100% of the time.
100%.
100%. Because of the source. You have a physical mechanical breach. You have a hole in the colon leaking feces, or a burst appendix, or a giant bag of pus. You cannot fix a plumbing problem with a chemical solution.
That's a great line. You cannot fix a plumbing problem with a chemical solution.
It's the absolute truth. Source control means you have to physically go in there and stop the contamination. You have to sew the hole shut. You have to cut out the dead organ. You have to find the abscess and put a drain in it and suck the pus out.
So surgery isn't just an option, it's the rescue mission.
It's the primary cure. The antibiotics are just the cleanup crew that handles the stragglers. Without source control, they are completely overwhelmed.
Okay, pillar 2, resuscitation. This goes right back to the third spacing nightmare. We said the patient is dry in their veins, so I assume we have to fill them back up fast.
We have to flood them, and we have to be incredibly aggressive.
Yeah.
We are talking about large bore IVs and pushing massive volumes of fluid, usually a balanced crystalloid solution like lactated ringers.
How much is massive? What are we talking about here?
In severe septic shock, we might be pushing an initial bolus of 1 or 2 liters, then continuing with up to 1 liter of fluid every hour until their blood pressure stabilizes and they start making urine again.
1 liter an hour is basically a fire hose.
It has to be. You are literally refilling a tank that is leaking into its own surroundings. You are racing against organ failure.
And sometimes fluid isn't enough.
Right. If they have lost blood or their red cell count drops too low from the stress and inflammation, usually if their hematocrit is below 25%, we have to transfuse packed red blood cells too. We have to ensure the blood that is circulating can actually carry oxygen to the tissues.
And I notice nutrition is listed here as part of resuscitation. That seems like an afterthought in a life-or-death emergency.
It seems like it, but remember, this patient is in a hypermetabolic state. Their body is burning calories like a furnace to fight the infection and heal. If you starve them, the immune system stalls and the surgical wounds won't heal. So starting nutrition early, either through a feeding tube or IV, is actually a critical part of this phase.
All right, now for Pillar 3, the chemical warfare, antibiotics. This seems really tricky because, as you said, there's an alliance of bugs, and you don't know exactly who is at the party when the patient first rolls in.
That is the fog of war phase. We call it empiric therapy. You have to make an educated guess, but it's a guess based on probabilities. You need to cover the usual suspects, the enteric gram-negatives like E. coli and the anaerobes like B. fragilis.
So what is the standard weapon of choice? Let's say for a young, healthy person with a burst appendix, a community-acquired infection.
For mild to moderate community-acquired infections, we try to use a targeted approach. A classic combination is a drug called metronidazole paired with a cephalosporin, like ceftriaxone.
Okay, why that specific combo? What does each one do?
It's a sniper team. Metronidazole is famous for one thing. It kills anaerobes. It absolutely destroys bacteroids. It's almost useless against aerobes, but for anaerobes, it is the gold standard.
So that takes out the fortress builders.
Exactly. Then you use the cephalosporin to take out the E. coli and the other aerobes. It's a divide-and-conquer strategy. There are also single drugs that can do both, like sulfoxetine or moxifloxacin, but the logic is always the same. You have to cover both sides of the alliance.
And what about the really sick patient? The one who is in septic shock in the ICU?
Then you stop playing nice. You bring out what we sometimes call the gorillacillins.
Gorillacillins.
It's just a nickname for the really broad-spectrum heavyweights. Drugs like piperacillin tazobactam, which most people know as Zosyn, or the carbapenems like imipenem or meropenem, these are the nuclear options. They kill almost everything.
So why not just give those to everyone? Better safe than sorry, right?
That's the temptation, but it's a very dangerous road. If you use carbapenems for every simple appendicitis, you breed resistance. You create superbugs that nothing can kill. So we have to reserve those for the patients who are actively dying or severely immunocompromised or have hospital-acquired infections with known resistant bugs.
Stewardship.
Antibiotic stewardship is critical.
I noticed a specific note about dialysis patients again. You mentioned they don't get IV antibiotics.
They can, but the preferred route is actually intraperitoneal. Since they already have that catheter in their belly for dialysis, we can inject the antibiotics directly into the dialysis fluid and let it dwell there.
Ah, I see.
It delivers a massive concentration of the drug right to the site of the war.
Yeah.
It's like airdropping supplies directly onto the battlefield instead of driving them in from the coast. You get much higher levels where you need them most.
That makes perfect sense. So once you've done all this, plugged the hole, filled the tank, dropped the nukes, what happens next? This is part 7, the aftermath.
It's backing off. If you started with a nuclear weapon, the meropenem, but the lab report comes back and says, hey, this is actually just a simple strep that's sensitive to penicillin, you switch to a narrow-spectrum drug. You stop the carpet bombing and switch to a precise strike.
Why is that so important?
2 reasons. It saves the patient from the potential toxicity and side effects of the bigger drugs, and it protects our future antibiotic supply. It's a key part of that stewardship we just talked about.
But there's a catch with the anaerobes, isn't there? You mentioned something called the anaerobe leg.
Yes. This is a really important clinical point. Anaerobes are notoriously slow and difficult growers in the lab. It can take 4 or 5, even 7 days for them to show up on a petri dish if they grow at all.
So the lab might report no anaerobes found on day 2, but I don't necessarily believe them.
Correct. Clinical judgment trumps the lab here. We know from decades of data that Bacteroides is almost certainly there in a burst bowel, even if the lab hasn't grown it yet. So we almost never de-escalate the anti-anaerobic drug like metronidazole based on a negative culture. We just keep it going. We don't take the risk.
Okay, so how long do they have to stay on these meds? I feel like the old school thinking was take antibiotics for 2 weeks just to be sure.
That has completely changed. The data now tells us very clearly that longer does not equal better. For a standard successful source control case, 4 to 7 days of antibiotics is plenty.
That's it, even for a major life-threatening infection.
As long as the source is gone. In fact, get this. If a trauma patient gets shot in the gut and the surgeon gets in there and repairs the bowel within 12 hours, we give antibiotics for 24 hours. And then we stop.
One day.
One day, because the leak was stopped before the bacteria could really dig in and build their fortress. The body's own immune system cleans up the stragglers.
That really hammers home the point about source control. The surgery is the cure. The drugs are just the insurance policy.
That's a perfect way to put it. And if the patient isn't getting better, if they still have a fever on day 5, the answer usually isn't to just extend the antibiotics. The answer is that the source control failed. It means there's still a leak or there's an undrained abscess somewhere. You don't need more drugs. You need a CT scan and probably another procedure.
That is such a fundamental shift in how we think about illness. We are so used to the pill being the solution.
In the abdomen, the pill is secondary. The physical integrity of the system is everything.
So let's zoom out for a second. We've gone from the microscopic alliance of bacteria to the massive fluid shifts of shock all the way to the operating table. When you look at this entire picture, the internal battlefield, what is the one thing that really sticks with you?
For me, it's the elegance of the logic amidst the absolute chaos. I mean, the biology of peritonitis is messy. It's rotting tissue, trillions of bacteria, systemic collapse. It's terrifying. But the treatment is beautifully structured. It's just 3 steps. Stop the leak, fill the tank, kill the bugs. It's a tripod of survival. It proves that even when the body is in total anarchy, there are fundamental rules we can use to bring it back to order.
I love that. For me, I think it's the humbling realization of what source control really means. We live in this world where we want a pharmaceutical fix for everything. We want to hack our biology with a pill or an injection.
Right.
But this condition proves that sometimes there is no substitute for mechanics. You cannot medicate a broken pipe. You have to go in with your hands and your tools and fix the structure. It's a powerful reminder that we are, at the end of the day, physical machines.
That is a profound way to look at it. You have to respect the machine and its plumbing.
Well, on that note, I hope your internal machine stays boring, sealed, and completely sterile.
That is the goal for all of us.
Thanks for diving deep with us. Stay curious, and we'll catch you on the next one.